Hi, my name is Mary Ellen Blum, and I'm a graduate student here at Excelsior College. And I chose to do my capstone project on enhancing communication among healthcare professionals and the terminally ill. I chose this topic for my capstone presentation and my capstone project based on my experiences as an ICU nurse, a hospice nurse, and now a nurse educator. On countless occasions, I was faced with situations in which patients and families would state that I was the first one to communicate honestly what was happening with them, and that they couldn't understand why no one had been honest, no one had been clear, and why was I the first one telling the things I was telling them. As a nurse educator, I witnessed through my students, again, on many occasions in which patients had unrealistic expectations for their family members. And so I chose initially death and dying, the subject of death and dying through many of my graduate papers, just because it was a subject I was comfortable with and had a lot of knowledge about. And then as I had to narrow down my focus for my actual project, it became increasingly evident that this was the way to go. And in my research, for my project and my presentation, and in reviewing the literature, I was introduced to, or I shouldn't say introduced, I was validated that this indeed is a problem, that patients are often not given clear expectations, not given clear ways in which the disease trajectory is going, or not given ample time in order to make informed decisions and have some of their end-of-life wishes made. So I decided to do the project in order to raise awareness to nurses and medical residents and other healthcare professionals in the facility that I work, kind of bring it to their attention, address the barriers that exist, provide them with tools in order to improve the way they may communicate with somebody, and then demonstrate ways in order this can be done, and demonstrate ways in order for that communication process to be improved. I see this problem being throughout the community, throughout medical community, in nursing homes, or long-term care facilities, and acute care facilities, and outpatient facilities. The problem is really everywhere. The stakeholders for this consist of patients, families, professionals, nurses, doctors, social workers, clergy, therapists, nutritionists. Really, truly, everyone involved in medicine really is a stakeholder. Some of the barriers that exist that created this problem, one of the biggest barriers was fear in having the discussion with patients about death and dying, fear of bringing up the word, people's individual fears on their own thoughts of what death is like. Also, a simple fear of being the one that destroys that hope or the wishes of a person. Another barrier that I've witnessed and experienced is a lack of experience in recognizing when someone is close to end of life. Really missing the signs so that there isn't time to allow the patients time to make those final important decisions for themselves and things that they feel they need to get done prior to their passing. Time is another huge constraint that we as professionals, especially in healthcare, face. We're often faced with an agenda throughout our day, and knowing that you're going to sit and have a conversation with a patient can take time, and we often are afraid of giving up that time because we just don't have it to give. I think one of the biggest things that is important is that we, through literature, it has been very clear with pretty much everything it's been supported that patients desire clear, open, honest conversations with their healthcare professionals in order for them to prioritize what time they have left. giving patients the time to have those final wishes made, especially for families with the unrealistic expectations, and really helping to not so much crush their dreams, but change what hopes and dreams they have. So that brings me into implementation and how the project was implemented. I chose Jean Watson's Theory of Human Caring and her 10 curative factors for this topic. I felt it was ideal when addressing the death and dying community and people at end of life. The 10 curative factors include addressing values of faith and hope, sensitivity, establishing a trusting relationship, the ability to express positive and negative feelings, individualized support, teaching and learning, gratification of human needs, spirituality, and existential spiritual forces. I really can't think of a better theory more suited to help me guide me through this project and presentation. All the components really impact what I was trying to communicate in this presentation, especially being the basis of improving communication. Excuse me, I feel as though dealing with the interprofessional team, working with patients, especially when it comes to their spirituality and the subject, and helping them find hope and faith when faced with end of life. The importance of just those basic communication skills that we learned back in our first fundamental nursing courses, with establishing that trusting relationship. And you really don't have anything unless you have a trusting relationship, and how patients and families really need that. Allowing patients to express themselves both in a positive and negative way, in the feeling of not being judged. One of the social workers I worked with and that was involved with this presentation made a great point when she said, by the time she works with these patients in this population, they are so sick of being talked to, they just now want to be listened to. And I thought, what a poignant statement, really, and again, really fitting in with this theory. Again, research continues to support that information that is given to patients and families must be honest. However, it is important to maintain hope, but not so much hope that it gives unrealistic expectations. Being sensitive to patients' needs, and again, showing that sensitivity, yet being empathic as well. And that's part of what, again, some of our tools that we use with our active listening helps demonstrate. So in our communication and in this project, one of the things I really tried to present was the importance of basic communication skills, and keeping in mind that 80% of our communication is nonverbal, and that listening helps to prevent missed opportunities. So again, the importance of open-ended questions to help engage patients and to help them state what they're feeling, listening to our patients, listening to them to help allow them to collect their thoughts and process what everything is being told to them. Using our interprofessional team and the interprofessional collaboration to help support our patients to really, and I'll say this again later too, but to really utilize them for their expertise in helping the patients in areas that we may be not so strong. Some of the leadership characteristics that I demonstrated and that were demonstrated in this project was really clear communication, communicating effectively with my mentor, with the interprofessional team. There was some areas in which I was not successful, and that I think is expected. Unfortunate, but expected. Delegating as well, asking for help, not feeling like it has to be all done on me or that I have to do it all. Creativity, creating the PowerPoint, creating the role plays, the use of the video clips to enhance the role plays. Again, my accountability, being responsible, accountable, professional, and the benefit I have of the collaboration with that interprofessional team. I think I'm very, that is a strength I have in communication and developing strong relationships and trusting relationships with other professions. I think identifying this need of improved communication can only help with quality improvement initiatives in the hospital. Again, identifying the lack of communication, trying to address it and change it, and then with the hope of enhancing that communication, then improving patient outcomes, improving patient satisfaction. And that brings us to my outcomes and the evaluation of my outcomes. So I developed 3 learner outcomes for my presentation. The first outcome was for participants to increase knowledge of communication between healthcare professionals and the terminally ill by 10% between the pre and post survey. The second outcome was to apply evidence-based communication strategies to modify the healthcare professionals' approach in addressing patients and their families at the end of life through role play. And the third outcome was to describe 3 new ways to communicate with a patient and family at the end of life for the purpose of an informed decision. So these evaluation and these outcomes really, I was definitely effective in the ability to meet my first outcome of the improved communication by 10%. 52%, well, we'll start with the first one. So 52% of, when you look at my survey, when you look at the survey, I had asked essentially questions of, had you ever initiated a conversation with a terminally ill patient? And 52% of the patients had not, or participants had not initiated a conversation. 48% stated they had initiated a conversation, yet 100% of all respondents felt that they could improve communication techniques after they had participated in this survey and seminar. The second question was, and response was, have the participants ever engaged in conversation with a terminally ill patient? In that survey, 33% of pre-survey respondents had not engaged in conversation with the terminally ill. 67% had engaged, yet 95% of the total respondents felt they would be more prepared to engage in discussion on goals and end-of-life care. And then finally, the participants' ability to list 3 ways to enhance communication with the terminally ill. Pre-survey, 52% could not enhance communication prior to the survey. Pre-survey, 48% felt that they could communicate. And post-survey, 90% of all the participants were able to enhance their communication and what they had learned in that seminar or that in-service with a dying person. So basically, therefore, 10% felt that their knowledge had increased. I do think that my evaluation, I could have done a better job despite multiple changes in our pre and post survey. After I completed and then was reviewing my results, I may have reworded some of the questions and put them in a different order, and maybe I should have made them a little more stable. Some of the other things that might have impacted our outcomes were we had a terrible storm the night before. There was quite a significant amount of flooding, which did impact people coming. In fact, my mentor, it highly impacted her home. I got quite a bit of verbal feedback that the role play was very effective as a learning tool, that they liked watching it in action. In the role play, we used the whole interprofessional team with a nurse, a psychologist, a clergy, and a social worker. And I actually had reached out to the palliative care community and the palliative care nurse practitioners and providers. And although they were excited and wanted to help, the head palliative care physician felt as though he was doing his own thing and didn't need to participate in what I was doing, which I thought was a bit unfortunate. Another kind of exciting thing occurred when one of my coworkers sent one of his students in to deal with or to care for a patient who had a palliative care and hospice consult. And as the student was walking in, the instructor was behind and saw one of the medical residents and had asked the medical residents if they had participated in this seminar in service that I had done. And the resident looked at him like he didn't know what he was talking about. And then the instructor said, 2 weeks ago there was an in-service over at the College of Nursing, and the resident said, "Oh my gosh, yes, that was really good." That actually made me cry. And I really did feel like, even though I don't have written documentation of this, I think the verbal was enough. And if it can change and impact one patient getting improved care, can really overwhelmingly assist the whole organization. And again, everybody, the stakeholders, the systems, the nurses, the doctors, the patients, the families, the entire team. It really can have a huge impact in promotion of patient care and patient-centered care. So again, that leads me into my analysis and my conclusion. I think one of the biggest things that I've taken from this capstone presentation, but as well as the course, is the role of a leader and how really an effective leader can really improve patient outcomes and satisfaction. I think good leadership, healthy leadership, is very aware of what's going on with the people that they direct, and I really do believe that open communication, the ability to help with quality initiatives, evidence-based research, care coordination, communication, really does affect improve patient outcomes. The cultural impact is certainly a large component as well with this topic and this population. Culturally, you need to look at both your own personal culture and how you view death and dying, but also the patients and the families. And I am speaking specifically to culture in this, essentially because culture has such a way that it defines people. It defines on how they think of death and dying, whether it's taboo, whether it's socially acceptable, whether you can be around the person at dying, whether it is something that they consider they deserve, or it's as a result of the way they chose to live. And that really is a huge component. And it's important for professionals to be aware of their own thoughts and feelings and beliefs, as well as what the patients may have. And then again, to bring in that interprofessional component, seeking out the people that may be able to guide you in that if you're unfamiliar with that kind of information. As far as reflecting on the knowledge, skills, and attitudes related to this project, I really think, again, teamwork and collaboration is a huge component. Understanding the team role, how people work differently and effectively together, bringing out the positives in people, learning to tolerate constructive criticism, and know it's not a personal attack, but it's actually something that can help you improve, and your skills, really learning those member strengths and each team member strengths, and building upon those to help improve the whole outcome for the patient. And then the values, really treating everyone with respect. Those are all a huge component. And it's important to implement these measures to improve patient care, to be accountable for those measures. Participation in data collection and other ways we use measurements can also help us with the knowledge and skills that we learned in this project in the development of our outcomes and the evaluation of those outcomes. As far as spirit of inquiry and the personal significance, really the identification of lifelong learning, and I think what came about this is developing something that I thoroughly believe in, want to continue to pursue and become a part of. There is a project called the Conversation Project I'd really like to be a part of in our community, really to help with our patients and our families, and our healthcare and other healthcare professionals in our area. I do think that the knowledge I have learned in the past 3 years is tremendous. I am an absolute novice in it when you consider the nursing education role. I have so much to learn, but I really do feel even just the little bit that I have learned has been really immeasurable, and I am so excited to be almost finished, and I am so excited to be able to carry on, hopefully, this project into really implementing it into our entire facility through a continuing ed, as a required mandatory educational in-service for all staff. I appreciate your time, and I thank you very much. And if you have any questions, I would love to hear from you. My references are as follows. Really, again, a lot of this is that evidence-based information for communication with our patients. And I hope that you guys have a great day. Thanks.